This episode was recorded in Q1 2026. The information provided in this podcast is for educational and informational purposes only. The views and opinions expressed by hosts and their guests are their own and do not necessarily reflect those of the Irish College of GPs. By listening to this podcast, you acknowledge that no party is liable for any direct or indirect consequences resulting from the use of the information provided. More information can be found in the show notes or at irishcollegeofgps.ie.
Profile of people coming into us has shifted a little, and yet for our referral options the pathways haven't shifted at the same time, and I do think that puts a lot of extra pressure on GP practices who are trying to manage distressed young people or distressed families, and it can be difficult, and you can wonder, am I imagining this? No, you're not. It's real. There really has been a big shift and a big increase in youth mental health, including depression.
Hello and welcome to the GP podcast from the Irish College of GPs with me, Dr. John Maher. Today I'm joined by Dr. Aoife O'Sullivan and Dr. Brian Osborne for part one of a two-part discussion covering their 2023 Quick Reference Guide on Managing Depression in Primary Care, available now on the Irish College of GPs website.
Hi, John. So my name is Dr. Aoife O'Sullivan. I'm a GP. I work in Cork. So my main job is in the Student Health Centre in UCC, working with, I suppose, mostly people from 18 to 30. And then I also work with the Irish College of GPs as a clinical lead in mental health.
My name is Brian Osborne. I'm a GP in Galway City and I'm an Assistant Medical Director with the Irish College of GPs.
For this conversation, we've decided to focus on the usability of the Quick Reference Guide for GPs in day-to-day practice. The front page of the guide has a Jump To box with 4 quick links to sections on talk therapy options, medication considerations, switching medications, and referral to secondary care. We began today with a broader conversation that includes epidemiology and the burden of depression on individuals and the health system, the phenomenon of increased mental health presentations by younger people in the primary care setting, an approach to the consultation and potential use of assessment tools, before focusing on the first of the 4 quick links on the guide, which is non-pharmacological options. Part 2 of our conversation is also available now in the show feed and picks up the conversation with a review of the other 3 links on the front page of the guide, before wrapping up with a discussion around potential audit and practice improvement initiatives in this area. You may find it useful to refer to the guide as we go along, and I've included a link in the show notes so you can get to it easily. I've also included a link to other resources mentioned today as usual, and you can also navigate through the show using the chapter markers. Brian began today's episode with an overview of the epidemiology of depression.
Thanks, John. So depression, as we all know, it's a really common illness, and up to 280 million people around the world are affected by depression, and it's the 3rd leading cause of burden of disease worldwide. 1 in 6 people in Ireland will have depression in their lifetime. And in the past year, around 6% of Irish people have used an antidepressant. So it's common and it's important in its own right, but also as a risk factor for other illnesses. So it's an independent risk factor for cardiovascular disease. So you have a 150% increase chance of having a cardiovascular event compared with the normal population. And there's a 60%, people with depression are 60% more likely to develop diabetes than their non-depressed counterparts. So it's important in its own right and as a risk factor for other physical illnesses.
Thank you. And there's an element of epidemiological information in the GPU as part of the introduction, Brian. And Aoife, I believe you've done some work more recently in the younger person cohort, and I think you've got some additional information on epidemiology since the guideline was published.
Yeah, so I suppose one thing I'd noticed in my work, and I'm sure many other GPs have noticed this too, is the huge increase in younger people coming into our practices with mental health issues, including anxiety, depression and suicidality. So this just has become very marked. And a little bit, I guess you wonder, am I just getting old here? Was this always the way? What happened? I don't remember this when I was in school or college. What's going on? And so I've been looking into it a little bit, and it's very well reported, both in Ireland and internationally, that in the past 15 years, so since approximately 2010, there's been a marked increase in young people presenting with mental health issues, including depression. So whereas in the past, I think some of the stats and studies go back to, say, to the 1940s, there was a very definite U-shaped curve where childhood and old age were pretty happy. And the bulk of mental health concerns, such as depression, tend to happen in that middle age category, 40s, 30s, 40s, 50s. So there's a very definite U-shaped curve, with childhood being kind of the happy place. And in the last 15 years approximately, both in Ireland, as I say, and internationally, that's changed. And there is now a much larger proportion of young people presenting with mental health problems such as depression or suicidality, deliberate self-harm. And it just means that this big shift has happened. And as we know, it takes a bit longer for services and resources to follow a shift like that. So I think as GPs, we maybe get caught in the middle, that the profile of people coming into us has shifted a little. And yet for our referral options, the pathways haven't shifted at the same time. And I do think that puts a lot of extra pressure on GP practices who are trying to manage, all the people turning up and coming to their doors, maybe distressed young people or distressed families. And it can be difficult, and you can wonder, am I imagining this? No, you're not. It's real. There really has been a big shift and a big increase in youth mental health, including depression.
Okay, that's really interesting, Aoife. Thanks. I also picked up on the word you used there, distress in young people, and I find that a very interesting word, because obviously, as you know better than me, distress does not equate to, say, depression, for example, or you can't diagnose a mental health condition based on somebody's distress in front of you. And that brings me on, Brian, to the person who comes into your clinic, where sometimes it is clear early into the consultation that this is going to be a mental health consultation. They can be challenging, they can be time consuming, and I suppose care is needed to make sure that you do your best or your utmost to land on the appropriate diagnosis. And I guess this is a podcast for working clinicians. Do you have any tips from your practice in your time working with patients with mental health issues that can help GPs?
Yeah, so I think, John, you mentioned it there. When patients come in, and it's obvious that it's going to be a mental health consultation, time is the number one thing that you need. And we're all different GPs. We'll all have our own different ways of doing things. But for me, when it becomes apparent, I let people talk. And I just let them get things off their chest without trying to interrupt them or without trying to direct them in one way or another. And sometimes just those few minutes of letting people talk, it's therapeutic for them, and it's answering questions that you would have in your head anyway, that you don't have to ask, be it around sleep, their mood, their enjoyment of life, their exercise, their social isolation. So if you give people time, I think that's the really good opening bit to the consultation. But I do understand that we're all busy GPs, and you're giving this person time, and there's a busy waiting room, and that's putting stress on you. And we do have to acknowledge as well that for public patients, mental health consultations are one of the things that are absolutely not funded by the HSE for GPs to look after. So if GPs don't have the time to give patients with mental health conditions, I understand that too. I think we do need to acknowledge that. And so that's one case where they come in with, it's obvious when people come in with a mental health condition, but sometimes you're seeing people repeatedly with physical symptoms as well. And they might be coming in and they're fatigued, and they might be getting some neck pain, they're having poor sleep. You've done various investigations, and your feeling is that maybe this isn't a physical cause. And that sometimes is harder to direct them to, that maybe there's a psychological overlay, and maybe questioning, gently, do you think this could be related to your mood, is a good way to try and open the conversation around that for people who aren't as sure of their mental health.
Okay, that's really useful. And just on that point, Brian, I suppose in terms of a general approach, the GPU does go into some of the assessment tools that you can use as a kind of a scoring system, the PHQ-9, for example, but there's also one in the GPU for postpartum women, and there's one for older patients too. And I guess from my experience in practice, in different practices, I've seen all kinds of approaches to it. Some GPs use them religiously, some not so much, some not at all. And I guess it's all within the realms of appropriate practice. Could I ask, what's your approach? Do you use them?
So, personally, I rarely use the PHQ-9, if at all. I would be more inclined to go to let the patient speak, go through in my own head the questions that I might have, and then if there is a diagnosis of depression, then on clinical acumen, I would divide it in my own head into is it mild impairment, is it moderate impairment, where there's the significant functional impairment in separate domains, be it at home or at work, and then into severe. So that's the way I'd use it in general. The Edinburgh postnatal depression scale we do use in our practice, and I think that's very helpful. Because you see women that have baby blues, which could be are normal, and the Edinburgh Post Depression Scale, it's a validated tool, and it can be very helpful in that period for me. But I think lots of GPs will have different approaches, and they're all appropriate, in the context that they're in, be it using screening tools or using your clinical acumen.
Thanks, Brian. Aoife, could I bring you in here, because I think your approach is slightly different to Brian's. Is that fair to say?
I think there's some similarities and some differences for sure. I agree totally with Brian that first few minutes of letting the patient, if again, I know we're all time pressured, but if you can, listening to the patient and maybe letting some of that distress come out, and that safe space of the GP surgery is invaluable. I guess I use the PHQ-9. I do use it, so my practice is a little bit different to Brian's. I probably don't use it as a screening tool though, because it's up there as a validated screening tool, and probably that's not really the way I use it. Like Brian, I think the using a patient history and a conversation is way more useful for gently assessing somebody's mental health. But where I would use it in my practice is if I feel that yes, this patient to me appears to be filling loads of the criteria for depression, and that's both myself and the patient agree on this, I will often ask them, it's in Socrates, it's one of the sort of forms, and it's just printed out, and ask them to complete a PHQ-9 to get sort of an idea, a snapshot of where their mood is at the moment. Because quite often somebody will come in and they'll say maybe they've had low mood or depressive episodes over the past number of years. I suppose now, if it's something very acute, this might not be relevant. But quite frequently, people will, when you gently explore it, they may have low mood episodes over years that they've never really gone to anybody about, and maybe finally they've summoned up the courage to come into you now. And you say, look, we'll just get this snapshot. It's just looking at these 9 questions over the last 2 weeks. How frequently you've experienced these symptoms? It's not perfectly accurate, we know that, but it'll just give us a ballpark. And from that, then, I'll use that with the history to say, is this, again, mild, moderate, or severe? Is talk therapy, if something is mild, is talk therapy the best place? Or if it's more moderate, do I need to be talking about medication in addition to talk therapy? If you notice that things are very severe, for example, there's a lot of thoughts of self-harm or suicidal thoughts, that's obviously a completely separate category, and maybe sends your conversation to a different place. But where I also find it handy then is if I'm reviewing somebody several weeks or even months later, I'll sometimes redo it as sort of a way of analysing if the treatment, whether that be medication or whether it be talk therapy or a mixture of both, has been successful. Because you can, say, look, your PHQ-9 was 18 the first time you came into me, now it's 12 now. So we've improved quite a bit. Okay, it's not perfect. Life, you're still having struggles for sure. But we can see that the therapy that we introduced has been helpful. Some of these therapies, as you know, they're kind of slow to act and they take a while, and it might not be always apparent. So I think it can be useful both as just an initial idea of where the patient's at, but also I think it's handy to use to see, to do later analysis to see, right, are the approaches we're taking useful? Is the patient feeling better? Are we showing that scores are improving? We're on the right track? Or actually, we're not on the right track. Time to change.
That's a really interesting way of utilising the screening questionnaire for non-screening purposes, Aoife, as you said, but actually for monitoring and for I suppose maybe objectively assessing response to therapy. And you remind me actually of my own GP reg days, in psychiatry, and my consultant at the time really hammered home this idea that successful therapy is not, I don't feel as bad as I did, and I suppose it could potentially be easy to fall into that trap of, well, you're not as bad, so things are going better, as it were. Is it fair to say that the treatment goal should be to try and get somebody back as close to their pre-morbid state as we possibly can? And I can see then how the PHQ-9 could start into that, if you want to use it or not. But I suppose what I'm getting at is trying to get someone back as close to their pre-morbid state is the name of the game, really, isn't it?
Absolutely. And it's just one tool that you can use. Obviously, they'll be telling you how they're feeling, and, the conversation and being able to talk is probably way more important than this. It's just a tool that you can use in addition to your history. Okay,
great. Thank you. Before we get on to the moving into more detail on some of the aspects of the GPU, the other thing that strikes me is the overlap that can occur in consultations like this, Brian. You can, and I suppose also, is somebody depressed? Are they burnt out? Do they have an adjustment disorder? And I guess care needs to be taken, doesn't it, around potentially labeling somebody?
It does. I think there's a lot of stress and distress in all ages, but as Aoife pointed out, there's a lot, especially in younger people as well. There's so much change and going on in the world, and someone coming in distressed because their assignment is late, or distressed because they've split up with their boyfriend or girlfriend. It's a crisis for them at that time, but that's not going to equate to a diagnosis of depression. And I think sometimes it's not a tick box exercise, but it can be useful to come back to the criteria for diagnosis as well. When we think about that, it has to be there the symptoms should be there for most of the day, for most days, for at least 2 weeks. And, it's the common symptoms that we all ask about all the time. Your sleep, your mood, your enjoyment of life. And I think a question that we all should ask really always is, even if you think this might be a mild case of, clinically, is there any suicidality, or do you have thoughts of harming yourself? Because that's an important thing that lots of people don't want to share because they feel embarrassed about that, but it's helpful to ask, and people like to be asked that question. So I think it is important not to just kind of brush that one under the carpet as well.
Okay, thanks, Brian. As I said from the outset, there's quite a bit of information in the GPU, and we don't propose today to go through, the kind of medical student element of, what is depression and the criteria for making the diagnosis. That is all there in the guideline for anybody who wants to refresh themselves. What I'd like to really focus on today is just the usability of the GPU as a document in clinical practice. So I have the GPU in front of me now. I'm on the front page. I've brought it up from my desktop, and there are 4 links on that front page. The first link is to management options with talk therapy. And if I click on that link, that's going to bring me to page 7 of the GPU and the psychotherapy section. And Aoife, perhaps you could talk me through the kind of options that are out there.
So I think this is really useful, John, because it's very hard to keep in your head all of the different options that are there. And I think just having that jump to is super helpful. So we try to ideally have what they call this biopsychosocial approach, which I guess boils down to don't jump straight in for medications. Do think about other options first. Now, the patient's preference you'd have to take into account here, and I think it is really important to get that as well. So you're going to be looking at 2 different things, both how severe the issue is. Is this a mild to moderate level of depression, or is it more moderate to severe? And again, what Brian spoke about there in the history, or perhaps using a screening tool might help guide you there. And because if it's a milder level or mild to moderate, that really ideally what we would be looking at is talk therapy as the first first option rather than jumping straight into medication. Now, admitting that sometimes a patient might come in and say, no, I've tried X, Y, and Z talk therapies already, and actually I'm here to talk about medication. So, like nothing is ever straightforward. But, it is worth certainly thinking, right, the first step here should be looking at talk therapy options. And this can be difficult in general practice because of waiting lists, essentially, and of financial barriers, that you might have some patients who can access private therapy or counselling or CBT, and others for whom that's just not financially an option. So the box that you mentioned just jumps you to all the different, what we'll call talk therapies or psychotherapy options, from CPSI, Counselling and Primary Care, which is a great option for GMS card holders in certain parts of the country. The waiting list can be better than others. It depends where you're living. But there's also the other options, often supported by the HSE and getting funding from the HSE. For example, Jigsaw gives free support for 12 to 25-year-olds. They can self-refer, it's important there, so you don't need to be doing referrals. But there is a referral option for Jigsaw in HealthLink if you want to do that referral. Jigsaw changed their processes in the past kind of 6 to 12 months, which means they're now going for shorter interventions, kind of 2 to 3 sessions rather than 6 to 8 sessions with each patient. And that's had a knock-on effect on their waiting list. So in fact, the waiting lists in my area for Jigsaw have improved immensely in the last couple of months as a result of that. So previously I mightn't have referred, and now I might think, yeah, we'll try Jigsaw. Pieta House can be extremely useful for people both with thoughts of suicidal ideation or thoughts of suicidality, as well as those who have had episodes of deliberate self-harm, because they can offer free sessions for those specifically with thoughts of suicidality or deliberate self-harm, and they can get up to 12 free sessions. And those Pieta sessions are based on dialectical DBT, dialectical behavioural therapy. So it isn't full DBT, but it is, based on DBT, which is really useful. Turn to Me offer some free sessions as well, and the link for that is in the GPU. And I've had 1 or 2 patients recently who used the Text About It, which is a free text service available. So if at 2:00 in the morning all of these services are closed, there is actually a text line that our patients can text, and you just get a response immediately through text, which again for younger people might be more acceptable. Sometimes they like to use text, but also importantly is available at a time when other services are closed and there might be a lot of distress. So it's called Text About It, and it's www.textaboutit.ie if you want to look it up for more information. And you basically text for free. It's a free text to 50808, and it's a 24-hour text service. I would use a bit because they offer low cost services for students, and they'd offer CBT. And more recently, again, just since September 2025, I have a new contract with the HSE to offer free up to 6 sessions of free CBT for men over the age of 18. So that's really helpful when looking at men's mental health, and is maybe not everyone might be aware that just came into place in September of 2025. SilverCloud, we can refer to SilverCloud online on the computer. Now with SilverCloud, I would put a caution in there that it is really for people with mild to moderate levels of depression. If it's at a moderate to severe level, then online guided CBT is not evidence-based. It isn't as helpful. So it really is for people more at the mild to moderate end. And I think it's important with SilverCloud that the patient would understand that they're not going to be seeing a therapist face-to-face on the computer. Online guided CBT doesn't mean a Zoom call. It means essentially doing an online workbook where you work through problems, type in your answers, and somebody reads those answers and feeds back to you. So I think that's helpful for patients to know in advance. So, I suppose another one I just need to mention there, and it's in the GPU, is social prescribing. That's really taking off, and it's really helpful for those with social isolation. We're getting great feedback from GPs around the country who are using it, and great feedback from patients. So I think I would give a shout out there to social prescribing as well.
Could I just give a shout out to the social prescribing piece that Aoife mentioned as well? In particular, Park Run, because I do it myself, and I've seen patients from our own practice that we've highlighted, and it's a really good community thing that people can do. It's called Park Run, but you can walk it, you can run it. It's not a race. And there's a really nice energy and atmosphere on a Saturday morning in all around the country. And it's a really easy thing. And it's good for mental health and physical health. So I just wanted to give a shout out to that before we got on to the medication.
Many thanks to Dr. Aoife O'Sullivan and Dr. Brian Osborne for speaking to me today. And don't forget to check the show notes for chapter markers and links to resources. We will continue this conversation in part 2, which is also available now in the show feed, so do be sure to check that out. The easiest way to make sure you don't miss an episode is to subscribe to the show wherever you get your podcasts. And while you're there, you might consider leaving a review on Apple iTunes or wherever you get your podcasts to help others discover the show. If you have any comments or feedback, or indeed any suggestions for future episodes, we'd be delighted to hear from you. You can contact us at podcast@icgp.ie. And that's it for today. Many thanks again for listening, and until next time, take care.